Welcome everybody to the Acorn webinar. We appreciate you joining us for Acorn, which stands for a Collaborative Outcomes Resource Network. We appreciate your time today. If you're joining us, some of you are joining us for the first time. Some of you are joining us as a refresher, and we really appreciate that. We hope that you get a lot out of this. Welcome. I am only going to be your moderator for the first part, and then Ashley is going to take over. So let's get started. A few odds and ends about the webinar. So I'm Roanna Newton. I'm the Provider Network Specialist, your moderator. The audience, that's you guys. You're in listen-only mode. So unless you've entered your PIN, you'll not be able to engage with us by phone. Or unless you're having technical difficulties like myself, you can't even engage then. We will have a question and answer section that's built into the webinar after Ashley's done with her presentation. So please don't be raising your hand during the webinar and asking questions during her presentation. Please be real mindful of that because we have built-in time for that. So she's going to be she's going to be really available to answer questions at the end. So also, if you think of questions later, you're welcome to submit them to questions@partnersbhm.org, and we'll be happy to answer them. Also, today's webinar is being recorded, and it will be posted to the Partners BHM webpage under the Provider Knowledge tab, Provider Resources, and then there's an Acorn icon there. And we're really excited that the Acorn tool has its own page on our website. This is for us to share information, training, and for you all to use as a resource. This page is an evolving site, and we will continue to add and develop it, but also we will be directing you to important links that are going on the Acorn site. So this is not something that's going to be static and staying put. It's meant to be a work in progress at all times. So just keep that in mind, okay? So I'd like to introduce our guest speakers today. So first I'm going to introduce Ashley. She began working in clinical psychology labs as an undergraduate at the University of Utah before leaving the field briefly to obtain a master's degree in Middle East Studies and Linguistics. Over her 7 years at Acorn, Ashley has worked as the head of risk assessment, quality assurance, has co-authored on the collaboration psychometric research, and now directs Acorn's content and training initiative. She enjoys making sourdough bread and is a retired beekeeper. Interesting. And then I'm going to introduce Jeb Brown. We'll hear from Jeb later on. Jeb earned his PhD in counseling psychology from Duke University in 1978. Before founding the Acorn collaboration, Jeb worked as executive director for the Center for Family Development, executive director of behavioral health systems at United Healthcare, and director of clinical programs for Aetna Health Plans. In 1998, Jeb founded the Center for Clinical Informatics. In 2007, Jeb and we call him Manami founded the Acorn collaboration and began work on the next generation clinical information system with a goal of greatly expanding the capabilities of older platforms. The Acorn collaboration is a culmination of lessons learned in managed care. If you improve patient outcomes, you shorten treatment times, you prevent dropout, and you increase the value of care. And now, the main event. Let's turn it over to Ashley and hear about the Acorn tool.
Okay, thanks for joining today, everybody. What we're going to be talking about is a little bit of a background on what outcomes-based care really is. But first of all, I would like to just explain what Acorn is because it's a little bit of a long acronym. Acorn is a collaboration of researchers, payers, and clinicians that was founded in 2007 by Talk and Jeb that aims to improve treatment outcomes in behavioral health. So it's not really just measuring outcomes, it's trying to figure out if we can improve outcomes. And it's based on the premise that you can't improve something that you're not measuring. Also, it's helpful to think that it's a physical place. So we're based in Salt Lake City, Utah, and we have a data center where we've been collecting outcomes data from questionnaires for the past 10 to 15 years, depending on which iteration of the Acorn system you're talking about. But in our current format, we've been here in Holiday for about 10 years. What do we know about measuring outcomes and improving outcomes? The clinician accounts for 5 to 10 times more variance in outcome than treatment methods. So that means there's big discussions about is CBT or EMDR or what treatment approach is best. But really, that's kind of a small part of the conversation. When we look at the stats, it's actually really important to pay attention to the therapeutic alliance and who is that clinician. Some clinicians are more effective than others. Clinician training and years of experience don't matter. So we find that after 50 hours of clinical practice, people pretty much end up where they are. That is counterintuitive, as we most often think that as you get older and more experienced, you become a more effective therapist. And the last thing we know is clinicians cannot achieve the same results without questionnaires. So if you're not measuring, you just can't exactly get the same level of effectiveness. So the formula here is routine measurement, and we'll talk a little bit about what that measurement looks like. It's a questionnaire administered at the beginning of every session, plus utilizing client feedback equals a better result for clients. Ignoring the research in our field carries risks to our clients. Just like the way analytics would apply in primary care, data helps augment the clinical decision. The same effect is true in mental health. So now let's get into what exactly is happening with our system. The first step is clients submit electronic questionnaires. Questionnaires are translated into usable information in our servers. And then the output. This is the most important step. Clinicians log into the Acorn, what we call toolkit, or you can think of that as a dashboard, just a place that you can see that data now in a meaningful way. And that's a website. And you can access information regarding cases there. Talk a little bit about questionnaire administration. A variety of standardized, reliable questionnaires completed by the client at each session. Takes 1 to 2 minutes for the client to complete. They can do that on a smartphone. You can text them a link. That's under our mobile forms option. You can pull it up on a browser, on a tablet, or a browser on a desktop. That's pretty much the gist of how a form is generated and then filled out by the client. The most important thing that I like to talk about here at the beginning or as a refresher topic is the Alliance section. You'll find this at the bottom of every Acorn form. The use of Alliance items has been shown to reduce no-show and premature termination. It's also been shown to contribute significantly to improved outcomes. So back at the beginning of this slideshow, I talked a little bit about how clinician really plays into the outcome of a therapeutic case. And how do we know how that alliance is going is actually from these 3 questions at the bottom. What people tend to do without any conversation about this section is be very polite, just like you would expect. Maybe they say, I agree with everything, everything's great, everything's perfect. So we encourage people to have a pretty explicit conversation about saying, I know I'm not perfect. I want you to be really honest. This is one of the most important parts of the form. And the more that you show you care about the form and that the more that you look at it and reference it, the more it doesn't just feel like paperwork, but it feels like important information where you're capturing the client perspective. And if they indicate something didn't work as well, then you have more information about how to improve that. So a little bit like we talked about, reviewing their responses with them. If it's self-harm coming up, you would know that from the dashboard in the toolkit, but you could also see it right after they hand the form back to you or the tablet back to you. 4 out of 5 times, clinicians underestimate dropout. So these are some images I just want to present to you before we go into the toolkit demo, so you kind of know what you're seeing. Graphs can be a little off-putting and they don't feel the same as talking about anecdotes or clients. It just doesn't feel very client-centric. So I want to explain how this is reflecting your effectiveness as a clinician. We call this effect size or improvement score, and this is the main thing you'll see each time you log in to the toolkit. This score helps give you a way to measure your effectiveness with clients while controlling for differences in caseload. One trend that you'll see that you shouldn't be too freaked out about is that when you start, you're getting used to it, your effect size is probably going to go up over time. So if you just have a month of data and you're not quite there in the highly effective range, just give yourself some time, and as long as you're in the effective range, which is above this black line, you're doing good. Also keep in mind, depending on which dates you're looking at, there will be a difference between completed cases, so cases that are over, and there will be a difference between those, and then if you pull that date range into the current date. So and that'll make more sense, I'll go into that in a bit. Because cases that are still in treatment they're not going to be as good as cases that are over. Something else we'll see in the toolkit today is the client progress graph. And the vertical axis is level of symptoms. So if we see these lines coming down, we know that's a really good thing. That's the pattern we'd like to see. And there's different ways you can break this out. You'll be able to choose what displays on this graph, like self-harm, alliance, substance abuse, symptoms, and global distress. Global distress is pretty much what it sounds like. It's a measure of wellness or correspondingly distress. If we see those symptoms coming down, then we know they're doing better. We know that they're improving in treatment. And there's a little bit more information which I'll direct you to on the Acorn website that gets into global distress. We also have the projected change line. This purple line is based on clients who are similar. So if you're using client registration forms, you're gathering information about their diagnosis, prior treatment, their age, things like that, and we use that information to create a projected change line for clients like them. You'll also see clinical messages. They can help warn you of trends associated with poorer outcomes. They can also warn you risk of hospitalization, suicide ideation, severe global distress. They also reflect good things, like if they've been showing willingness to participate in the alliance section, it'll let you know that that's a great thing you should try to capitalize on and keep going with that patient. And these will also let you know if this case is going so well that you might begin to discuss spacing out sessions or even ending treatment. So Acorn is an ongoing learning process. As we use it at places like Partners and all over the country, we get feedback about how to improve, and we've learned some things. Because we've been doing this for a long time, we can kind of look at the numbers. And what we've found is that clinicians who look at the toolkit regularly improve. And that doesn't mean that they're going in and generating forms. It means actually that they're going into the dashboard and they're looking at their effect size and their client graphs and their clinical messages, and they're kind of using that to inform the treatment. We don't want to replace your clinical judgment, but we do want to augment it. We also know that clinicians who don't look at their toolkit do not improve. So we have a nice big control group of people who get signed up but don't log in. and we find that their effect sizes stay the same. And we know that clinicians who improve and are looking and then stop because they feel like they're doing really well actually regress. So their effect sizes start to go down after they stop looking at their data. We're going to go into the demo section next, but I want to just draw your attention to our FAQs page. If you ever need to request a demo for yourself, since we've mostly got LIPs on the phone today, let me know. Or if you know of an agency who might be interested in getting help or having questions, they can email me at ashley@clinical-informatics.com. And as we're working on making more tutorial videos, we will be posting them on our YouTube channel. You don't necessarily need this link, but it will be on the partner site later. You can also just search in the YouTube search bar for Acorn collaboration, and it'll pull up. So these two things, our facts page and our YouTube channel, are constantly evolving. We're getting more things. We're going to be recording some clinician tips about how they use Acorn and putting those in. So I'm just going to pull up the toolkit now. And some of you will be very familiar with this page. Something to know, actually I'm going to log out. A few things about this. If you forget your password, you can just type in your username, send me my password. You can submit a help desk from this page, which is answered by my colleague Justin every day, or Kyle. They're really responsive, so feel free to use this link right here. It also has a link to our website, which is acorncollaboration.org. I'm going to refer to that as our website, and this is the toolkit, just for future reference. Okay, so we're in. The first thing I'm going to do is set my date range to all, just because I want to show you guys a lot of cases. Here is the improvement score, or that effect size that we talked about. You can see in my demo organization that it's not in the effective range, so we'd be hoping to pull these scores up. There's some other useful information that you'll find here, and you kind of don't need to worry about this filter section. I'm going to hide that. That's if you want to pull up information about the diagnostic group, the payer, the clinician, gender, all sorts of things you can do with that. But that's not really relevant to what we're doing today. What we can see here too is the case count. So I have 19 cases. 13 of those, so 68% of my cases, have repeat assessments. 19 of my cases, so all of them, came in the clinical range. That's probably not a realistic reflection. Most people have some cases that aren't in the clinical range. Clinical range with repeat assessments is, yeah, as we mentioned, 13. And over here, you can see the percentage of client improvement. This is just another visual graphic to help you understand how things are going. Significantly improved is the dark green. Somewhat improved is the light green. No change is tan. And then somewhat worse and significantly worse are over here. Now we're coming down to my clinicians. This would be the view if you were working in an agency and you had multiple clinicians that you were supervising. For you as an LIP, you will only see your own data. So you'll just have lots of clients over here, but it'll all have your name under the clinician name. Some things that we have are the client ID. That's a number that you set. Then we have the number of times they've been seen, the most recent date they've been seen. And over here we have that clinical message. I'm going to hover over that. Okay, so hopefully that has helped you understand what this whole front page is about. There's one other section that you want to look at when you're logging in to look at your data, and that is by clicking on the client ID. This is a little link right here, so 7671 is a link. And this pulls up the client graph that we talked a little bit about. I'm going to choose some items to show on the graph and then click refresh. And now we can see those here. So what we're seeing here is not a good thing. They came in with some self-harm, and it actually went down. They were doing better for a while, and then it came back up and got worse than it was when they initially came in. So this is a case we really want to pay attention to and be inquiring about as to why that self-harm is spiking up. They're also experiencing quite a few social symptoms or social problems, as we can see by this light purple dotted line. Substance abuse is also something that you would want to address with this client. And the alliance is we're just glad that they're filling in the alliance section, but that shows that they're kind of answering honestly the fact that this isn't just the same perfect across the board. If that were the case, you would see the green dotted line here at the bottom, hovering around the bottom. But it's showing that they're willing to be honest with you about how the alliance is going, and that's something you can use to your advantage to help them. If you want to pull up what was happening on a certain date, you can find the corresponding date here on the horizontal axis. So I'm going to click on March 8th. And we are able to see what they filled in. So with that substance abuse, it looks like they're drinking alcohol and using illegal substances sometimes. That might be something I want to delve into. And we see down here that they're putting some thought into the alliance section. We're coming back to our dashboard view. Something I want to show you is maybe you don't have time to read all your clinical messages. This is a lot of stuff. You can probably intuitively know that the red means they're doing worse and that green is good. So let's just hover over a positive clinical message for a moment so you can read that. And this is a pretty normal patient. It's not really doing great. It's not doing horrible. Up here at the top, there's some other ways we can filter our data. For example, what if I just want to see high-risk cases? You'll notice that our visuals are changing because we're only looking at people who aren't doing well. And you'll see down here, it gives me a short list of people to focus on. You can pull up those client graphs. So now that we kind of understand what we're seeing here when we log in, I'm going to show you how to generate a form, just for those of you who are new, or maybe if you've submitted a form in a different method. We have 3 ways of generating forms. You at Partners will not be using the printable forms, so you only have to worry about these top ones. And if you need a refresher, we have a little informational page here to help you decide which form to generate. I'm going to show you a mobile form generation right now. So the first thing it'll ask me is for a site. As an LIP, you probably won't have sites. I'm going to select one of our adolescent forms. I'm going to fill in the client ID. And just a little background, you probably know this, but the client ID is something that we don't assign here at Acorn. It's something that we just put in the system. You tell us what that is. So if you ever have any curiosity about how that number is generated, direct those questions to Roanna. And then I have 3 options of sending my form. The first one is our most popular, and that's the display URL. So you probably know that means link. I can have an iPad or a Kindle. On that device, I would have a QR scanner. This is a QR code. And when I open up the QR scanner app, I would scan this barcode. That would immediately take me to this page. And what we're seeing here is the mobile format. Even though I'm on a computer, we still call it the mobile because it works on a phone. It works on any device with a browser. So I'm seeing the mobile format of the Acorn form. And because I answered all of the information at the top, like my organization was already set for me, I picked Site 4, I typed in that client ID, and my clinician ID is 30. That's all filled in for me, and this is ready to hand to the client. Today, it'll be filled out by the youth themselves, not their parent or an adult who knows the youth well. And they'll just go through clicking on these buttons. We're going to drop down to the Alliance section so you can see how that looks on the mobile form. And then Submit Form. Why this image comes up after submitting is actually so that that youth can hand the tablet back to you and you can see what they said. That's a really nice way to show them that you're looking at the Acorn form and using it to inform what your discussion is going to be that day. And this also just gives you a message to let you know that it was submitted effectively. And it's in the system, so that is going to show up in your toolkit in about 10 to 15 minutes. Now, that doesn't mean you can't see the form, so this part is a little bit tricky, but I'm going to show you how to see a form that was recently submitted but might not have shown up in your data yet. That's the Forms Processed tab, and that's under the Home menu. When I click on Forms Processed, I can see what I submitted a few moments ago. Also, earlier in the webinar, I had mentioned that you can text a client. Now, if you text the link to a client, how are you going to see what they said? And this is how you would do that. You would go to Home and Forms Processed. Then you'd be able to pull up what they had submitted. Okay, so we've gone into mobile forms and we've generated the URL. I'll show you how to do the text one next. So again, we're under Forms and then Mobile Forms. You can always plan to use mobile forms. There's specific cases where people would like to generate an Adobe form, but with that it gets a little more complicated. There are instructions for that if you get an error linked here on what form should I choose. But feel free always to just use the mobile forms format. That'll get us all the information we need. So I'm going through these fields. This time I'm going to do an adult form rather than an adolescent form. And instead of a display URL this time, I'm going to use the text message. This is useful for people doing telebehavioral health or just increasingly used by clinicians who find it convenient. There's a message autofilled, so on your client's phone, this will show up. Your provider requests that you fill out a short survey before your session. This is kind of nice because they can do it before they get to the office. And then you're going to click go. You'll get a confirmation here that a text message was sent, and that's my phone number. It just showed up on my phone. And what they're going to see there is that mobile format. They'll be able to click on through all those buttons and click submit. Okay, so I am going to open it up for questions at this point. You can ask a question by clicking on the raised hand icon on your GoToWebinar dashboard. And apologies, I gotta figure out how to unmute the people. Okay, I'm going to unmute Tracy Butler first, if I can. Let's see, or maybe I just have to read her question out loud. Okay, how do you address security when opting to text a client the link? Great question, thanks Tracy. Essentially, the way that we handle security is with the texting. Is we're just trying not to gather PHI in the first place. So when we're generating that mobile form, we don't know their name. As a clinician, oh, so maybe you mean that Acorn has their phone number. Actually, if you can, I would. Can you give me a little more information about what aspect of security that you're concerned about? Is it the phone number, having the client's phone number in the Acorn system? And then while I'm waiting for that, I'm going to go to Lynn James Smith. Hang on.
Can you hear me?
Yeah, is this Tracy?
This is Lynn.
Oh, this is Lynn. Okay, perfect.
Can you show us some more information on the reports? There are times when I have run a report and I'll look at a number and then I'll think, oh, I should have printed that out, and I'll go to run the report again and may get different information.
Yeah, one thing with the reports is that you can change that date range a lot, and also you're getting more information all the time. So I'm not sure if this, I'm just going to show where that's located. So under the reports menu, you'll see here the login report, just for background for anyone who doesn't know. And what we'll see here is a lot of ways to differentiate. So we need to make sure if we're running a login report for my whole agency, that it's selected all sites. And we'll also need to make sure that we're running it for all users. And then
if I'm not wanting to run it for all users, is there another option there?
I think, let's see, if we put in, I'm wondering if you would be using the clinician ID here. And that, if that would just pull up, yeah. So I could type in one of my clinicians' full name as long as I'm using their user ID and just look
Okay.
at Jay. He's one of my fake clinicians.
Right.
Or we can do all. So one thing you just want to, I do this all the time, is like I forget to set my date filter and then I'm confused later. So if you want to look, oftentimes what people will do is for the previous month. So we want to just do September 1 through, and sorry, that was the wrong date box. September 1 through the last day of September, September 30th. And remember to submit. That will give us the right information. And let me explain what you're seeing here. You know this, Lynn, thanks. Thanks for bearing with me. What you have is the org, then you have the user. So Jerry Smith is that dummy clinician I was mentioning before. The login date, the last time Jerry was using it, time online, number of requests means things that they clicked on. And it looks like he clicked around, but he didn't pull up any client graphs. So that just gives me a little bit of information. So this is how we assess if people are using the toolkit or not. Okay, I'm going to come back to, go ahead.
There are some times when, for example, I would pull up that report or a report, and then I would, let's say I go into something, I pull up something on Jerry Smith and I go back, and there are times when I'm having to log off and log back in to get all information again. It's like after.
Yeah, that is that's kind of due to the nature of the fact that our platform is run on Microsoft.ASP. It times out sometimes. It's something that you kind of just have to be mindful of. And if you're ever having this be buggy or glitchy, something that almost always fixes it is logging off and then logging back in. So long term, we're trying to troubleshoot that, but just so everyone knows, in the short term, that'll almost always fix any timing out that's being experienced on the page.
Yeah, I almost find that I have to log in and out like with everything I do. It's like I'm logging in and out a great deal to kind of, I'm just needing to verify that that's just the way it is. I'm okay with that. I just need to know I'm not doing something wrong.
For long sessions, that'll oftentimes happen.
Yeah, this is Jeb. I know that there's also somewhere in the code we specified a log out time for security reasons, and it's fairly short. We went through a whole security audit, blah blah blah. And the idea is, if you walk away from your computer, you get locked out. Nobody can come up and play with it. But it's annoying.
Yeah.
Right? It happens.
This doesn't feel like a timeout time. This feels like like if I go into Jerry Smith's information and I look a little more detailed at Jerry Smith, and then I want to go back to, let's say, the whole office or the whole organization or one particular office, then I have to log off and log back in again.
Yeah, that sounds like a bug.
Okay.
So if you have a bug like that, the best thing to do is really document it well. What time did you log in? When did it happen? And that's a little bit of work on your part, but that's what's going to be most meaningful to Jen, our programmer, because typically we do hear about these big bugs really quickly. There's about 2,000 forms submitted each day. So it's not, we need, the take-home message here is we need a lot of information about exactly what happened, and as much as you can provide in terms of screenshots. So if you're not familiar with screenshots, there might be a key on your keyboard to actually take a picture, or take a picture with your phone of what you're seeing and experiencing, and that'll really help us communicate that to Jen.
I do find that I do find that you guys are very responsive, that sometimes that I'm not always sure that it's going to get, our clinicians are just doing other things, and they are not going to pay attention to the fact that they logged in at 11:53 and submitted 3 forms this way, and then they X'd out on their browser instead of doing, those kinds of things. And so I recognize that you can only do what you can do. But I do find you to be very responsive.
Yeah, and it is frustrating because it's definitely a work in progress as we figure out how to address things and make things more reliable, make them visually more appealing. There's a lot of components that we're trying to improve, and we really appreciate feedback. So don't be shy about submitting a help desk or emailing me. Also, don't be shy about asking for personal one-on-one help. Using technology in healthcare is a huge hurdle, and we are not going to be frustrated with the fact that it's a hurdle. It's something else you have to do, and even though the Acorn questionnaire is short, it's still something you need to learn about. I'm going to come back to Tracy's question, which was clarified regarding any PHI. So the way that we address this, and feel free to email me with any further concerns that you might have, Tracy. But what we're trying to do is we're trying to de-identify this data as much as possible. With our client IDs, they're not something that we have access to. We don't have the address or name of that patient. We also are HIPAA compliant, so everyone who works with our data has to be HIPAA certified and goes through a yearly training for that. We've also been audited with an SOC 1 and 2 audit to make sure that our systems are capable, available. They're not going to go down even if the electricity goes out. We've really gone through the steps to make sure that we're addressing data availability and security. But going forward into the future, we try to really keep it minimal. We don't want to know anything more than we have to help you improve as a clinician. I'm going to go down to a question from Krista Shipley. How do I add another location to certain providers, and how will it show me their login dates in the report? So that is a great question. One thing you have to do with sites, when you get set up, if you're a provider who has sites, you will actually need to email us here at Acorn to add that, because it's something that we don't give you the ability to do. And that's actually a good thing, because once you go from being a siteless org to being a site-based org, you have to start filling in the site ID field. If you just put the org ID, so let's pull up a form so that this is more clear. Do an adolescent form. Okay, so you'll see here that I had to generate organization 899, and I also had to pick a site. Once you move to sites, which you can accomplish by submitting either a help desk or emailing us directly, the names of those sites and the numbers that you'd like them to be numbered with, you can't leave this blank anymore, because it won't, when your forms get to Acorn, we won't know where to route them. So that's just something that I wanted to let everyone know. That's not so relevant to the LIPs unless there are LIPs working at multiple sites, but feel free to email us on specifics with that. Oh, sorry, Tracy, I just saw your message about not having a microphone. Thank you. And now a question from Rhonda Mitchell. I have many clients that are over the age of 60 or so. They're not tech savvy, so no printable forms. Also, is there a monthly expense from the clinician to sign up to use Acorn? Typically there is. So for some of our clients, there is a cost, but for partners, your use, my understanding is that it's covered by partners. Also, and I'll give Roanna a moment after I answer the second part of this question to confirm if that's true or not. This is the part about the printable forms. It is also my understanding that partners does not do faxed in forms. So those printable forms are not something that as a partners clinician you should be doing. Now I'm going to turn it over to Roanna to address if that's correct.
Right, Ashley, that's correct. It's our requirement for all of our providers and LIPs that all of the forms must be submitted electronically. And you were also correct when you said that the monthly access fee is currently being covered by partners. That is true as well.
Perfect, thank you.
Ashley, am I still connected? This is Lynn.
Yes, you are.
Yes, you are.
The clinician can print all the forms they want. We print forms. Partners doesn't care that we print our own forms, but then we enter them electronically. So for the clinician with all those clients over 60, they can print out forms and hand them a paper form and then have themselves or someone else electronically submit the form.
That's an option.
Yeah.
Maybe, yeah, that's true. That's definitely true. Most people like to do the electronic submission, but it certainly isn't. You could print it out if that's advantageous to you. I have another question here. Can a clinician have more than one location on their profile? That is definitely possible for an agency. So sometimes people set sites to be like not a physical site, but a certain type of clients. So maybe like the inpatient people have their own site. There's a lot of ways you can work with sites if you're working in an agency and not independently. And you can be associated with multiple sites. We have another question from Lynn. Isn't the clinician, when texting to a client with their client number on the text, breaking a HIPAA rule? I will look into this. I do not know at this point that there's a specific HIPAA rule about texting. What we have here, I see the gist of your question, but because all of the information is de-identified on our end, as of now, I do not believe that it violates HIPAA. Next question from Sandra Farley. If you know that one of the clinicians entered a wrong ID number on a consumer, is there a way to correct that? Yeah, that's a great question. Let me show you the fastest way to correct that. You don't even have to go to your email, but if you happen to correspond with Justin or I, you're welcome to email us directly, but just go to this help menu and go to submit request. This will autofill a bunch of information for you, so this is a nice fast way to do it. Then you would just type a message. So again, as much information as you can give us, the faster we can help you. So if you entered a wrong client ID, let us know. We'll know who you are because your email address will be auto-filled, but let us know what the wrong one was. So 2014 was wrong. What you meant to enter was 2013. That's the right one. And then the time. So those three pieces of information are going to give us what we need to help you out. And then you would just click send request. It's pretty nice. Just reading a question right now. This is a question about custom forms from Sandra. She wants to know if the way that the forms show up, so back when we were looking at the form, if we could have a gray line to help it look more clear to the client. So I'm going to pull up a mobile form since that's the easiest method. Here, I feel like on the printable forms, that's definitely more of an issue, a relevant issue. The mobile forms format is pretty clear just because it puts those lines between it already. If that's not sufficient, we could talk about other ways of visually generating this, but you'd run into some costs because it would have to be programmed for you. So I'm not exactly sure, but we could get into things like that through email correspondence. There's a question from Krista. What email address am I needing to send it to? When your client fills out an Acorn, there is no email required. Now, what you may have seen is that we do have an email option, which is right here. Almost no one uses this, just because it's easier to generate that URL for the mobile form, either using the QR code or pulling it up yourself and handing it to the client in a browser. We almost never use this email, but if you do want to email the form, it's very similar to the text message option. And instead of entering the number of the client, you would enter their email address. So exact same method, you'd fill out these fields and then you would type in their email. Okay, question, if I wanted to print the form, how would I go about doing it? You would come under Forms, and you would go down to Printable Forms. And same method as before, with any other method of form generation. What we're selecting is if you have sites, you need to fill that in. That's who you are. The client ID, language, either English or Spanish. I'm gonna generate an adolescent printable form right now. What it gives you is a link. And for me, it's opening up an Adobe format of this form, which is great. That works really well with our system. And you'll see this form is not in the mobile format, like we've been seeing throughout this demo, but it's actually all written out. You would click on the print icon and make sure your printer was hooked up, and you should get that all printed out. The only thing that's left blank here is the session date. Everything else should be auto-filled. Question from Donna Duggins. Do you have any experience of using Acorn with ACT teams? And I'm going to turn this over to Roanna because I know I've heard of the ACT teams, but I can't speak to that very well.
Wait, I just had to take myself off of mute there for a second. So I don't think we have anyone that's using it with their ACT teams right now. That being said, I'm not sure that there's that anyone has come forward to say we don't want to use it or we do want to use it. Most people, when they started out, wanted to implement it in a certain service setting first to see, to kind of get their feet wet. When there's a group dynamic setting, then everyone wants to know, okay, well, which clinician is going to be the one that's primary filling it out? Because you don't want to do too many acorns if there are multiple clinicians that are seeing someone. So that has been the conundrum and the question that we get asked a lot. So then it usually comes back to who is the lead on a particular team, if it's a team approach or that kind of thing. And so it just tends to fall to whoever is the lead or the primary therapist and that's the one who would be the one who would do the Acorn for that particular consumer. So I can't say that I'm aware right now of any agency that's using it with ACT. That's not to say that's not true. I'm just not thinking off the top of my head that anybody is. I'm just not sure. But I'm not saying that it can't be done either. I think it could be, but I'm not sure that it is or isn't happening right at the moment. I don't see why we couldn't try it.
Great, thanks, Rana. I have a question here. I don't want to jump ahead in topics, but how do I sign up to get an Acorn ID and let the people know Partners is covering the costs? From Rhonda. So Rhonda, you just want to email Roanna. If you're on this webinar, I assume that you're a Partners affiliated clinician, and so she can get you set up with the next steps in terms of registration. Does that sound good, Roanna?
Right. Actually, that web page that I talked about in the very beginning has the steps outlined. So you can check out our web page because that lays out the steps right there. You know, if you're not actually, you know, if you haven't gone through the credentialing process, you have to do that first. So I do need to put that out there as well as a caveat. So just so you know that. But go to our website because that Acorn page has it all laid out, the steps that you need to go through, okay?
And I'm going to pull that up since we're all together. This is a great time to show that. Here's the URL for that, providers.partnersvhm.org/acorn/. And down here, you'll have some of the information we talked about today. What is Acorn? Why would I want to use it? We have a great video that our colleague Justin made about what outcomes are and why we should care about them. And then we also have a link to the toolkit registration. Once you submit this, it's just a few simple questions, mostly contact. This is also where you set up your client ID numbering scheme. This will give you a download to the Excel sheet. You fill it in, and then you can email that to Roanna. Okay, we have a question from Krista, and we're getting down to the end of the questions, it looks like. So feel free to submit in the next few minutes if you have thought of a question. We hand out paper forms to patients, but then they are entered in electronically. I'm having trouble entering in under my login admin due to site number, ? Is that normal if I'm supposed to have access to all sites? So with this, the one thing that I do know is that if you have sites, then you'll have to make sure you're not leaving that site ID field blank. You'll have to fill it in every time. If I clicked blank, that might give you some trouble. I think there's a specific reason that that's an option. Like, for example, if you want to, in the morning, for some of our clients, they want to print out all of their forms and hand fill in the site ID. But if you forget to put in the site ID, that can create problems down the line. Typically, in answer to your question, it's not a problem that you're associated with multiple sites. We can have Jerry Smith site 1, Jerry Smith site 2, Jerry Smith site 3, and to my knowledge, we don't have any reported problems with a user being associated with multiple sites. Next question from Lynn. I recently learned that until a clinician has 50% of their clients having done multiple forms, the effectiveness isn't apparently helpful. Are there other things we should know about reading effectiveness information? That's a great question. So that's one of the things the toolkit will show you is how many repeat assessments you have, and I'll show you where that is. Right now there's two things you want to look at. One is clinical range case count, and then we want to look at clinical range case with repeat assessments. So the way that I explain this is like your effectiveness isn't really, you can't show that you're getting better if you don't have multiple points of assessment. That's why we encourage administering Acorn at every session. But certainly what we see a lot of with lower effect size orgs is people coming in and doing one form and then never doing it again. That doesn't give us any information, essentially. What you want to do is get those clinical range patients submitting at every session. And the more that they do it, the more accurate your effect size will be. And the better it will be. Jeb, do you want to speak a little bit as to what the clinical range means and how we make sure that it's not conflated with people who you may be seeing who are not in the clinical range?
Sure. I won't cite the psychotherapy literature, but this goes back quite a ways of differentiating between a normal and clinical range. Broadly speaking, if you're in the clinical range, you have scores typical of people seeking mental health care. If you're in a normal range, you have scores typical of people who've never sought mental health services. But there's an overlap. So about 25% of the people seeking mental health care will have a score in their normal range. We don't report an outcome on that because they don't improve. The scores are already low. There's really not much place to improve to. So it makes the results look really bad if we include that. So we developed the practice of only reporting on the clinical range. And if anybody wants the references on this, Ashley can provide them. We published quite a bit on it, but that's the reason why we do it that way.
Great, thanks, Jeb.
Let me just add, if you do it that way, and then you compare the results you get to what you see from well-conducted clinical trials, you get almost exactly the same results. The real-world results are comparable to clinical trials. And part of that is because in clinical trials, there would have been a selection criteria. You don't treat somebody for depression unless they score high on a depression measure, let's say. So it makes it possible to compare our results in the real world to results from well-conducted psychotherapy studies. And we get virtually equivalent results.
Great, thanks. I had a little add-on to the question about having trouble with entering sites, and Krista said she was asking about how to add sites. So just reiterating, you can do that through submitting a request. But again, this is something, if you need to add sites to your organization, that's something that we have to do for you. It's not something you need to worry about. On the contrary, if you're a clinical admin and you would like to add new clinicians, that is something you can do under the admin tab and then add other users. I have another question from Donna. Will the state allow Acorn to replace the requirement to use NC TOPS? So I will give this my best shot and then Roanna can correct me. I do believe you have a choice. Is that correct, Roanna? You can use Acorn or NC TOPS.
Okay, it takes me a second to get off of unmute, sorry. For that delay, but right now, you have the choice, but I'm not sure that that's going to be always the case. So just kind of keep that in mind, okay? So, right now, you've got that option, but I can't I can't be predictive that way. Who knows what the state is going to require in the future? So. It's always important, I think, going forward that you have an outcome measurement of some type, and so I think you're definitely on the forefront of things to make sure that you're prepared for that. So I definitely think that's the way to go at this point.
Great, thank you. Krista had another question that she can't see the drop-down sites. Let's correspond after, either through submitting a help desk request or emailing me, and I'll put my email back up. And then after the webinar, I'll log in using your credentials and see if we can figure it out. To me, I'm wondering if your org hasn't been set up with sites, but I'll be able to tell you more afterwards. I have a question from Gail. Can the data be uploaded or talk with an electronic health record? This is typically something we don't cover in like intro because it gets into some technical stuff, but I think it's a great question. We do have several clients who have Acorn speak with their EMR, so to speak. As you can imagine, that can happen a lot of different ways. And I'm not going to go into the various methods in which that happens, but essentially to give you a general idea, it's something that's usually undertaken by your managed care organization. So like, it's not something we do for an LIP or maybe even an individual agency, just because it's prohibitively complicated and expensive. Usually you have to have a programmer on your end. Now, if you do, it's not terribly hard. We do have directions, and what happens is that you'll log into your EMR, and then there will be a place for you to log into the toolkit within that EMR and fill out the Acorn, and then go on with your typical EMR routine. Jeb, does that sound vaguely correct as to what you've been doing with clients?
Yeah, and we do have, I mean, it's customization every time. There's so many EMR platforms out there. It's like, you know, you've seen one. I mean, but the simplest way to do it is we give instructions on how to embed a link. And if you're in your EMR and you click on it, it goes to the toolkit immediately without a separate login. It passes forward the information, and we know who you are and so forth. And that link can be customized. So we have one large private entity, but we're integrated in EMR. And so if they have a particular case open, they can click on the link and it will immediately bring up the graphs for that case, for example. Once you're under the hood of the EMR, that's all real easy to do. But the organization has to have somebody that can do the programming on the EMR end. At our end, it's real easy. The other thing we've done in a few cases is transfer data overnight using an FTP site where they send us data, we send information back. That's kind of kludgy. But we've done that. That's been the case with some larger organizations like Kaiser Permanente. But personally, I think it's easier just to embed the link, and then you've got access to all of the capabilities of the toolkit from within the EMR.
Perfect. Okay, so wrapping up, thanks everyone for your attention. Yeah, again, I just want to stress that we work with you. This isn't something that we expect you to never have questions about and just get out of the box and use. We're growing all the time. We're enriched by your questions and criticisms. So feel free to continue to use our educational material. I'm going to show you our informational website just because you may find information that's useful to you on here. This is our site, acorncollaboration.org. I'll pull that up for the last slide as well, so you have that. I want to draw your attention to the FAQs page just because of how it's organized. If you have, the way that I'm building this out is broken down by topic. So if you wanted to look into what is that global distress thing I talked about earlier, you can click on that. That'll take you to our research as well. If you want to know more about Alliance, we have a section for that. You need a little bit more information about administering the form. You have questions about form creation. You want to understand how to look at the graphs better. And then we have a general section and a data and summary page. So also, if you think of something that you would like submitted to this page, feel free to email me. At the bottom of every Acorn collaboration.org page, we have a search bar too. So that search bar is really nice. Okay, I'm just going to leave these on the screen. Does anyone have any last questions before we end today? All right, well, thank you for joining, and we look forward to corresponding with you.
Thank you, Ashley and Jeb. We appreciate you so much. We appreciate your time to do this for us today. Thank you, thank you, thank you. And thanks so much to all our attendees. And we'll get this posted on our website within the next couple of days, okay?
Yeah, we'll post those slides. Partners will post those.
Absolutely, we sure will. Yep, absolutely. All right, everybody, take care and have a great day.